Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
Hi, speeding car in the background. We are going to talk mucosal melanoma because I think we haven't actually done a proper podcast on that subtype. So we'll talk mucosal. There's a couple of main papers I think we all think about in this space about efficacy of checkpoint inhibitors. Maybe on another occasion, we can actually think about KIT inhibitors in this disease. Controversial, maybe, not in widespread use. But the checkpoint inhibitors, there's two papers. There's a JCO paper, and then there's an Annals of Oncology. But before we do that, I wanted to ask you how many times you've gotten called for an emergency on a plane. Is there a doctor on the plane?
That's a good question. I've lost count.
Yeah, it's too many, right?
Yeah, very large numbers. First one, I don't think I've told you this story before. I was a brand new qualified doctor, 1996, and my then girlfriend, I'd met her when she was a Rhodes Scholar in Oxford, and we were going back to a family wedding. Actually, well, I was going to say Cape Town, is in Stellenbosch, which is close to Cape Town, basically. Christmas, and I get a call.
She was South African then?
Yeah. Is the doctor on the plane? So I'm this kind of brand new qualified doctor. We were working so hard then, before like modern hours and stuff like that. So me and my friend, we were in a team together. All we did was work and sleep. And sometimes we'd get in the evenings and we were so tired, we're too tired to eat. We'd fall asleep during meals, that kind of thing. So we were just absolutely exhausted. Various stories. Anyway, so is there a doctor on the plane? And I think I'd gone to sleep anyway, so it's like 11-hour flight or something to Cape Town from London. And it was maybe 4 hours into the flight, I think. And we were then over the middle of Africa, basically. So no way really to divert the plane too far from London. And there weren't any good and there was someone who was Swedish and had chest pain, a guy, in his 70s or something like that. And no kit on the planes to help diagnose this, no sort of speaking to anyone on the ground. And it's he was sick. I mean, he was sweaty and stuff. There's something wrong with him, right? And so, it's probably an inferior MI, or maybe the guy was sick, clearly sick. They had I think they had a spig, so you could measure blood pressure. His pulse was a little bit thready, that kind of thing. I think he probably had an inferior MI, maybe a pulmonary embolus. I think it may have had some aspirin on the plane, so I think maybe gave him some aspirin. I didn't think it was GI. So I do all this sort of stuff, and the guy's like lying down on the centre seats of a jumbo jet, basically, and they've moved everyone else out of the way. And then basically, like after 10, 15 minutes, the guy, he was Swedish. I can't speak Swedish. He couldn't really speak English. And so we were kind of communicating in German because I can understand a bit of German and he could speak a bit of German. It wasn't straightforward at all. Anyway, and then within, say, maybe 10, 15, 20 minutes later, this other guy walks up and he said, I heard the call, for a doctor. My name's Dr. X, Y, and Z. I'm the head of the coronary care unit at Baragwanath General Hospital in Johannesburg. Okay, so this is like the biggest hospital in the whole of Africa, okay, right? Probably there's like a coronary care unit there with hundreds of beds. The guy just like walks up and takes over. So then for the whole of the rest of the flight, I was doing obs on this guy every 15 minutes, okay? Like blood pressure, pulse, all that sort of stuff. We get to Cape Town, and this is like 6 hours later or something like that. The guy was still fine. Ambulance comes out on the runway, basically. There was no messing around with like immigration, and like literally took him off as soon as and honestly, I didn't hear what happened to the guy afterwards. I was in pieces, and then my girlfriend picks me up, to go to this wedding. And I think the flight had, the ambulance thing had delayed everything, basically. So we arrive after the bride, her sister. Okay. I'd kind of meanwhile got changed in like the back of the car on the way from Cape Town Airport to Stellenbosch. And I was just in absolute pieces. So anyway, so the only thing, I don't know if I'm allowed to say this one, the only nice thing of that was British Airways. On the way back, they upgraded me to business class. And I'd never flown business class before, and that was thoughtful, and I think the guy was fine. So that's the first time. I've got other stories, including with other airlines. There isn't time now, being less generous.
Yeah.
And I've had situations where I've had to make diagnosis on long flights, which have saved a diversion. And all the consequences of a diversion, not least financial, to the airlines. And I've had absolutely nothing back in return, not even thanks.
Oh, yeah, absolutely right. And actually, these days, British Airways may not even be as generous. The same airline these days may not give you the same. I will say, in our new lives as podcasters, if this really takes off for us as a thing, I know what our next podcast should be. It should be us just having all our physician friends and colleagues on, because every single one of us has these stories.
Yeah. Oh yeah. How can you not?
Every single one of us. And most of them are not great.
No.
They do not end well. They're real things, which tells you they announce that for almost always real things. But that's the next one we should do.
I'll just tell you another bad one actually quickly. This wasn't an airplane, but my wife and I were on holiday in Mexico, Yucatan, and we were driving to Chichen Itza, and we just had one of these amazing Beetles, VW Beetles, because at the time, this is 20 years ago probably, that was that was fun. So we're driving along I don't know if you've been there, all these flat roads on the Yucatan Peninsula. Then up ahead, there is this scene of absolute carnage, basically, where a minibus has gone off the road, rolled over a few times, glass everywhere, and we are the first responders, my wife and I. And luckily, my wife had some gloves with her, so we go in, right? And then it was like a triage situation, basically. So there were Italian tourists, these people, maybe 15 or 20 of them. Some of them, like a lot of glass embedded, into their, bodies. But a lot of them were screaming and shouting. We said, look, we can speak Italian. You're okay.
Yeah.
Like, please stand over there. And then we had to triage the people who weren't making any noise, and look for pneumothoraces and that kind of thing. And again, luckily to my memory, no one was dead at that stage. And then the emergency people maybe turned up 20 minutes later and they took over. But we had 15 or 20 minutes trying to triage all the passengers in this minibus. So yeah, blood everywhere. Hence the gloves, blood everywhere.
Can only imagine.
Anyway, that's put a bit of a down on the whole thing.
Yeah. Good. On to mucosal.
Yeah. So should we? Why don't we do the JCO one first? Because I guess that's the one that first came out. A bit of background. I mean, I guess most people know about mucosal melanoma, but we lump all these mucosal melanomas together. But the fact is, of course, that they'll start in different parts of the body. So you've kind of got the head and neck ones, and then you kind of got the pelvic ones. They're the commonest ones anyway, and then anorectal, female genital tract. I mean, that's the way I carry on.
The commonest ones in what sense?
The ones we see in clinic is what I was thinking. I mean, there are other rarer ones than those, but go on, are you thinking of something else?
No, Casey Coots, who I work with at Colorado, she's a super talented PhD in this space. I think she, and maybe, probably she has a good handle on this, is it's all regional. So in Asia, it's nasopharyngeal, much more common. In the US, UK, maybe we'd have to look at Europe and Australia, it's more anogenital.
Yeah.
So I wonder if once you start factoring in like all of the Asian population, is it actually more common here? But then that's in a very specific.
Yeah. No, I mean, that's a fair comment. And obviously, in Eastern Asia, it's the commonest type of melanoma that we see, as we know well. So what do we know about these intrinsically? Well, they'll often present late. They can be aggressive. You might not get symptoms in the same way that you would with a cutaneous melanoma. So there's all of that kind of stuff. And the point of the first paper in the JCO, Sandra D'Angelo's the lead author and Jed Wojcik's the senior author, is that those with metastatic mucosal melanoma had actually got into some of the checkmate trials kind of along the way, which I think benefit of hindsight was a good decision, because sometimes these patients do get excluded from trials. So let me just double check this. So the studies that were put together for the purpose of this paper were a phase 1 study, it's quite a small number of patients, dose ranging study. There's a biomarker study, these were BMS studies. Checkmate 066, which was Nivo versus chemo first line in BRAF wild type. Checkmate 37, so that was Nivo versus investigator's choice chemo in IP refractory. And then Checkmate 67. So basically all these studies were sort of put together. And then the big question was, you've got the cutaneous patients, you've got the mucosal patients, you've got nivolumab monotherapy, you've got ipi-nivo. How does that pan out? That's the crux of this for me.
And you were involved with these, right? I mean, because of your Checkmate involvement.
Yeah, and I think I may have even presented the data from this at SMR in Boston, maybe, before the paper came out. I'm kind of slightly hazy on that, honestly. I've got bad memory for stuff like that. But anyway, so yeah, I mean, I think we thought as a group this was a really interesting thing, because it's a real issue in clinic, and we just didn't really know. Go on.
I think you do have a good memory, because that November 2016 SMR was in Boston, and this paper looks like it came out in January. And I remember, because that was a big, it was finished on election day in the US, and I took a early flight back to Houston, middle seat, crammed, couldn't open my laptop or do anything because I wanted to watch election results come in at home instead of, being on a plane for it.
So does that mean that you missed my talk, or if I indeed did do the talk, which I'm not entirely confident about? But
you should feign ignorance. I don't know.
Anyway, so I guess
what was so important there is that there's a Wagamama in Boston near where that meeting was.
Oh, I wish I knew about that, actually, because I ended up going to have one or two kind of coffees and stuff like that at places that weren't Wagamama, but that's a separate story. In any case, so I don't think it's too much to say about toxicity, really, that we don't know already, and we don't need to labour that, I don't think, i.e. there's more toxicity from ipi-nivo than there is from nivo mono. I mean, I would cut straight to the PFS just to maybe talk about that a little bit. Yeah, figure 1. So figure 1A is the mucosal. And you can just, if you look at the numbers there along the bottom, the total number of patients there, I'm just doing the maths now, it's going to be about sort of 150, 160 in the 3 different groups. There's ipi mono as well. I should have said that before. And then if you look at the cutaneous numbers, this is figure 1B, then you've got, basically 1,000 patients, 1,100 probably. So then the cutaneous PFS curves, I think, behave as you would sort of expect, and I'm not sure there's too much to really say about that. Relative, I mean, maybe you would say that there's a relatively brief duration of follow-up, actually. So it's kind of, not really much out beyond 12 months. So that's a sort of a caveat, I suppose. And then if you look at the mucosal at the top 1A, numerically, ipi-nivo is doing best. That's in yellow. Nivo mono is just below that. But, maybe a big take home for me here is the ipi mono. I mean, pretty much everyone, that's 36 patients, had progressed by the 6-month time point, if you see that.
Can I say, as we, our group in Houston was reading this paper and sort of digesting it, I think we actually missed this figure. I actually don't think we spent a lot of time on the PFS here. We really focused on the objective response rates. And
honestly, so I think that's right. I've always focused on that as well, actually, and that's what I've carried around in my head if I'm in clinic or I'm kind of teaching or that kind of thing. But what's the moral of that story? Always look at figure 1, do you think?
Supplementals, demographics, figure 1.
In this podcast, Sapna and James discuss the importance of looking at figure 1.
Don't stop.
Sorry, I interrupted you.
No. But actually, it's a transition. I mean, I don't know if we even said the response rates here. We said it before we started recording because I was saying you have a photographic memory. But it might be important to say those response rates, but then that actually takes us to a more, maybe slightly more contemporary paper that came out during the pandemic that was 500 or so mucosal patients that talks about PFS.
Yeah, we should say the response rates, though. It's 37% for ipi-nivo and mucosal and 23% for nivo mono. I mean, I don't think you can really say much about response durability here, limited follow-up, that kind of thing. But that's the kind of thing I had in my head from here, that it looks like, that felt like these are small numbers, et cetera, but it felt like that was potentially a worthwhile difference, I guess, in a difficult to treat disease. Anyway, so then if we talk about the other paper, this is in Annals of Oncology 22, Dr. Dimitri, who I don't know, Dr. F. Dimitriou, sorry, I should say. Yeah, is the lead author. Georgina Long is the senior author. And like you say, this is a really good number of patients here. And the title, I should say, as well, single agent anti-PD-1 or combined with IPI in those with mucosal melanoma, an international retrospective cohort study. So if you just look at the abstract, it's 25 cancer centres here around the world, so globally, and you've got those that were treated with anti-PD-1 monotherapy, got those that are treated with ipi-nivo. And again, in terms of efficacy readouts, response rate, PFS, OS, also analysed by primary site. I'm sure we'll come back to talk about that in a minute. And I guess really for me, the take home here and the context with the other paper is that it didn't really look like in this data set the IPI was adding too much in terms of efficacy, but then they're beginning to see these interesting differences with different parts of the body and whether that might be relevant for efficacy, which I think is an important point. So I guess one question is, how do we sort of put these two data sets together for clinical practice? And then the other question is going to be about biology. And, we're lumping all these things together as mucosal melanomas. But, as you hinted at when you're talking about geographical distribution, they're probably quite different diseases from each other, I guess.
Probably quite different diseases, and there are probably some pharmacogenomic differences at play here. We know this for chemotherapy, that there are certain CYP3As, 4As of the liver that metabolize chemotherapy differently in different groups. And you wonder if we're doing the right thing thinking of this as one disease, or is it anatomically different diseases and then also geographically? I mean, many times, and I think 067 you guys might have done this where you separated it by geography, and here it would be important for us to make sure we carve out Southeast Asia as its own place. So a couple of things. Do the PFSs sort of line up and OSs between these two data sets?
I think the PFS is going to be the kind of key question, given, there's loads more mature follow-up from this Annals paper than there was for the JCO paper. But if you look at the PFS, so I'm now looking at figure 1 in the paper, I think it's in the same ballpark. The lines are really close together.
5 and 4 is what the text says. 5 months for monotherapy, 4 months for combo.
Yeah, so which are medians, and then in the JCO paper, PFS median again 3 months, 95% confidence interval, basically 2.2 to 5.4 for mucosal, and that's nivolumab, and then for ipi-nivo 5.9 months, confidence interval 2.8 to not reached. Mm-hmm. So, I think that's pretty similar, and they're such different data sets. I'd be fairly relaxed about that.
Well, we were sort of chatting about this, that the D'Angelo paper is checkmate trial. So it's sponsored studies that would have had pretty symmetric data collection, might be the way to say it. At least they were pretty, hopefully, consistent across those trials and as a sponsor, and then how each site was going to report. So progression, confirmation of progression, response, etc., toxicity. The Dimitro paper, 500 plus patients retrospectively worldwide, but not necessarily clinical trial patients. So could be subject to recall bias. We don't necessarily know in the methods, how did they find each of their mucosal patients? Was it just everybody remembering the last, mucosal patients they treated? Was it some systematic way to get them all? So there's going to be a little bit of recall bias there. And then just collection bias that, they're may not be scanning at the same intervals and may not be reporting symmetrically. Having said that, those PFSs feel roughly similar. It's about 6 months for checkpoint inhibitor. Now, what checkpoint inhibitor? Because one study, it's the single agent that gets you 5 months. The other study, it's the combination. The response rate still, I think, is helpful here. So then in the Dimitro paper, they do talk about response rate. And here they start to parse it into different anatomic sites, right?
Yeah, so you're looking at table 2, right?
Table 2, I was, and now I'm just scrolling like a mad person. Yeah, table 2, objective response by location.
Yeah, so it's sort of pretty busy table, isn't it, basically? But if you look at overall, I'm just looking at anorectal, 33%, urogenital, 26%, nasooral, 32%, and then that's kind of broken down by race and treatment as well. I mean,
and just so I get a chance to say the words anorectal and urogenital.
Oh, sorry.
Anorectal and urogenital.
Should I have let you go first?
No, only teasing. But if you look at that far right column, the combo column, because let's just agree that we all think this is a difficult disease, often diagnosed later, worse prognosis, maybe because delayed diagnosis. So we want the best option. And if the highest objective response rate, despite no difference in PFS OS, might come with combination, I think most of us are still going to reach for combination. It'd be hard to justify single agent, though we know you can take single agent and there will be a small tail on that curve, a small portion of patients who exist on a tail of the curve, even with this mucosal. But that far right column, what jumps out is not the fun to say anorectal urogenital, it's the nasooral patients that have a 40% objective response rate to combination. So I think in this busiest of busy tables, it's a slight take-home message that the authors were trying to make, right? That perhaps these nasoorals sort of, not with any statistical confidence, but just numerically seem to be generating a high response rate. Is that how you read it?
Yeah, maybe, but I mean, I just think it's difficult, honestly. I mean, maybe those are some of the ones with the lowest disease burden and like normal LDHs, and where maybe the pelvic ones don't. They've got liver mets more, for example, and so on and so forth. So I think that's tricky. I mean, my other comment, getting back to the activity of IPI mono in mucosal melanoma from those PFS curves, is that it's very little indeed. So you've got a patient in front of you in the clinic. Let's say you treat them with anti-PD-1 mono, and then they don't respond, which is the most likely scenario. Is there a second line there? If it is, would you use IPI mono? I'm not sure I would, and I don't actually. So I'm thinking to myself, well, actually, this is a bad disease. I'm probably going to go with IPI-NIVO up front if the patients are fit enough to do that. And then the other thing I might just chuck in is performance status as well. And again, I'm drawing a parallel between the two data sets, that we all know that the kind of real world data sets, obviously the patients are fit enough to have had systemic treatment, but it's not regulated, I don't think, in the same way in clinical trials. So in other words, that the checkmate patients are very, very likely to have had better performance status. And then this is probably a whole separate conversation there won't be time for today. But, when we've looked at checkmate 67 in the past and looked for these differences, PS, for example, I've got a pretty strong feeling actually that people with the better PS are getting the most benefit from IPI-NIVO as well. But, that could be a slight rabbit hole to get into today. And we're already on 25 minutes.
Yeah. Okay, good. So what else to say? I have one other comment. Casey was teaching me, because again, she's really studied this area deeply, and we may have an institutional series we can hopefully share at some point, but she is also noticing there might actually be a slightly different pattern of spread in upper, maybe that's science of the obvious. It didn't come across as that obvious to me, but she did say, they don't all necessarily spread the same way. So that obviously has implications on benefit and response in certain areas.
Okay. Right. Very good.
Anything left to say? BREF status? Anything here?
No, don't think so. I think that the take home is all about, I guess what we think is the best treatment, as we've discussed, and then these are heterogeneous. Go on.
Yeah, well, maybe we haven't finished here. I mean, let me just ask you, you have a mucosal patient in clinic. Are you giving them adjuvant therapy?
I think we definitely talked about that before, but just to round it out though, so what's the evidence for adjuvant anti-PD-1 in mucosal, very small numbers of patients in trials? Is it biologically plausible that there's some benefit, just as the next point? Yes, I think so. Is the benefit likely to be as large as cutaneous melanoma? Obviously not. So what I would tend to do with mucosal patients in clinic is really follow them up to the end of the adjuvant window, do some scans there around 8-10 weeks. And then other things being equal, if they hadn't relapsed, and many mucosal patients will, and if they have relapsed, I'll treat them with ipi-nivo. I don't think it's unreasonable to give adjuvant anti-PD-1 monotherapy. It's not going to be right for every patient, but I don't think it's unreasonable.
Neoadjuvant?
Yeah, so again, it's a bit of an extrapolation question in a way, isn't it? I think pretty small numbers of patients in trials. Would it be biologically plausible for someone who's got a mucosal melanoma with lymph node involvement to benefit from neoadjuvant treatment? Yes, I think is the answer to that. Would I want to do it? Yeah, I'd want to have the option of doing that. I mean, this is a conversation with surgeons, very, very importantly, and with patients. But yeah, with the assumption that we're not going to get strong data for this particular question in the near future, I think if you can do it, it's a reasonable thing to do.
Yeah, I mean, I would refer people to our supplemental data for S1801 in the NEJM publication, because we have a small cohort of acrals and mucosals, and I think all the mucosals got randomized to neoadjuvant therapy. So obviously, hard to analyze, A, because it's small, and B, because they all got randomized one way. I don't know. I mean, this is a question I think we were meant to ask. Christian never did. Maybe we were supposed to fact check it. We didn't do that either. Were there mucosals on Nadina? Mucosals or acrals?
We need to check.
Yeah. And then you have a metastatic, good, just getting this rapid fire at the end of our podcast. So you have a mucosal patient in front of you in clinic. Let's call it a pelvic mucosal, as you say. Based on these findings, PFS is about half a year. OS is anybody's guess based on what you do next. What are you liking in this space? Are you sticking with combination?
Yeah.
Do you like any of the relativity data that they've shown on
No, I think I'd be sticking with combination at the moment. I still think it's the kind of, the gold standard, at least for potency. And just a quick segue there, though, but the lifileucel data for mucosal, which I think quite a lot of people know about quite well at the moment, and certainly all the patients do, it really looks like it's a great option as well. So if I had my dream sequence, as it were, it would probably be ipi-nivo followed by lifileucel. It's very small numbers and all of those different caveats, but that looked like a pretty solid efficacy signal, I have to say.
Mm-hmm. Or maybe that's a disease where the primary surgery should be the TIL harvest. Like primary tumor surgery should also be a TIL harvest / banking.
Yeah, definitely.
Because so many of them recur and then use.
Yeah, that's absolutely right.
Great. What else? What else? Anything else?
Not that I can think of.
Okay, super.
So we're done. Did you stop recording?
No, let me hit stop. Thanks. Have a good rest of your day. It's the weekend, but not for whoever's listening. It's not their weekend necessarily.
Well, might be 2 in 7 chance.
2 in 7 chances. All right, cheers.
28%.
It's fast math. I like that.
Oh, come on.